Hi, this is Dr. Bhargava. Here's the next video in the series Body Imaging Case Review. This is our first patient. They presented with abdominal pain and distension, and a CT of the abdomen and pelvis was performed with IV contrast. On these representative axial, coronal, and sagittal images, we find findings classic for peritoneal carcinomatosis. So in between the abdominal wall musculature and the bowel loops is the omentum, and the omentum is thick with heterogeneous enhancement of abnormal tissue, which is seen on this axial image and also right here on the coronal image, and some of it is seen here on the sagittal image. And so when there is solid tissue, nodules, fat stranding in the omentum, we want to raise the suspicion for peritoneal carcinomatosis. Now, where is this coming from? She should have a primary tumor. On the sagittal image, we see that there is a complex cystic mass in the pelvis. It has some peripheral enhancement, and this is most likely a ovarian malignancy, which is leading to peritoneal carcinomatosis in this patient. Here's our next patient, and this is one of those weird clinical situations of foreign body insertion by a young female. And so a CT scan of the abdomen and pelvis was performed without contrast. Axial, coronal, and the sagittal images show that she has successfully inserted a bulb in her vagina. And so clinically, this was very challenging for the clinicians to take out this foreign body from her vagina. And one of the things I tell trainees repeatedly is that whenever you see something which is hyperdense on CT and leading to artifacts on the cross-sectional images, always go to the scout image, because that's where you will be able to better assess that foreign body. And so here's the scout image showing the bulb in her lower pelvis, which we earlier localized as being in the vagina. This is our next interesting patient, where on this single radiograph, frontal view of the abdomen, which includes a part of the chest, abdomen, and some pelvis, we are looking at a G tube which has been inserted. Here is the tube, and some oral contrast has been injected to see if it is in the bowel. So this does not look like it's opacifying the lumen of the bowel. And so to localize it, always have a low threshold to do a CT scan without contrast. Anytime you are in a situation where contrast is being injected to confirm the position of a catheter and you're not able to localize it well, get a CT. And so we got a CT, and look at the axial images here, the coronal image and the sagittal image. The G tube has been misplaced. The bulb is in the subcutaneous space right there, and the contrast is seen disseminating into the subcutaneous fat. And so this catheter should be removed and replaced. Here is our next patient. We are looking at two images from their CT of the chest with contrast. The axial and the coronal images, they show a very prominent ascending aorta. And the interesting finding is that around the aorta circumferentially, there is abnormal soft tissue density. And so you want to measure the attenuation of that density. And thickening here in this region could be post-surgical, but if there are no post-surgical changes, like in this patient, you have to raise a suspicion of an intramural hematoma. This can be seen in patients who are hypertensive and may or may not progress to aortic dissection. This is our next patient. They presented with history of trauma, and a CT of the abdomen and pelvis was performed. On the axial image, we find this linear low-density focus in the spleen, suggestive of laceration. It's also seen here, and it is seen here. And so you want to use the AAST scale to give it a category or a class based on the system. The interesting finding here is that whenever you have a solid organ injury, spleen or in the liver, spleen being the most commonly injured intra-abdominal organ in patients who have trauma, and the second most common organ to be injured is the liver. Whenever there are findings there, you should scroll up and down in bone windows to look for any associated bone injury. Frequently, you will find that there are rib fractures adjacent to these intra-abdominal injuries. So here is that rib fracture that was picked up also after the diagnosis of a splenic laceration. This is our next patient. They were complaining of abdominal pain, and a CT of the abdomen and pelvis was performed without contrast. On this axial image, we find that there is this complex structure in the right side of the abdomen. It has some air or gas, some peripheral hyperdensity or calcification, and some internal very dense focus. And on the coronal image, this looks like something man-made. It is linear and hyperdense. And this is the appearance on the sagittal image. And so again, you want to go to the scout image to see what this is. And so here's the scout image. This turned out to be a gossipiboma, or a lap sponge that has been retained after a surgery. So you can see that hyperdense structure here, and also the focus of gas around it. So these things frequently lead to abscess formation, and that's what we see on the CT scan. This is our next patient. They presented with right upper quadrant abdominal pain, and right away we can tell that the gallbladder is abnormal. They have acute cholecystitis because the gallbladder is distended. There is mural thickening. There is some surrounding fat stranding and some pericholecystic fluid, and there are discontinuities in the gallbladder wall. So this enhancing focus here is the gallbladder wall that is thickened and enhancing, but there are parts where it's discontinuous. And so frequently when patients have acute cholecystitis, the pathology will rupture towards the liver, forming abscess. And so we see part of that here, that there is discontinuity in the wall and there is fluid that is extending outside towards the liver. Also, you will find that the adjacent liver is hyperemic and it will show enhancement. And that's the finding we see right here. And so this patient has complicated acute cholecystitis, which rupture and abscess formation towards the liver. Here is our next patient. This is a young female who presented with shortness of breath, and initially pulmonary embolism was suspected and a CTPE protocol was performed. And on this axial image, we can see that here is the main pulmonary artery. That's the left branch, and the right branch is almost completely occluded with this opacity or density. And peripherally, there are findings suggestive of lung infarct. So this was called as a PE, saddle-shaped embolus in the right pulmonary artery branch, leading to a right upper lobe pulmonary infarct. But the patient did not respond to anticoagulation, and a tumor was suspected. So the patient underwent a whole body FDG PET CT, and here's a rotating image. We have a focus of intense uptake in the chest and a focus of mild uptake in the peripheral right upper lobe. So the hypermetabolic focus corresponds to the clot or the suspected clot that we saw earlier, but you wouldn't expect a clot to be that hypermetabolic. And so what could this be? The infarct is better visualized on these lung window. It's a wedge-shaped ground glass opacity in the peripheral right upper lobe. So she's definitely developing infarcts. Could be a tumor thrombus also if we suspect that this is a tumor. And here is the fused PET CT image. And so she was investigated further, and it was found that she had a primary tumor of the pulmonary artery, a very rare tumor, which is called pulmonary artery sarcoma. So she underwent surgery and a pneumonectomy with removal of the entire right lung. This is our next patient, also very interesting, presented with abdominal pain, and on that initial CT scan, a hypodensity suggestive of abscess formation was reported in the spleen. And so thinking that this hypodensity is a pus, a catheter was placed and it was drained for several weeks, but it didn't go away. And so a needle was put and biopsy was performed and FNA was performed, and it turned out to be a splenic lymphoma. And so lymphomas can be hypo-enhancing. That is what we see here, and can be confused with an abscess, especially if they are not accompanied by lymphadenopathy, like this patient, and there was a solitary lesion in the spleen. The patient actually underwent an splenectomy. This is our next patient. They were evaluated for abdominal pain, and a CT of the abdomen and pelvis was performed. The uterus is enlarged and it shows a mass, enhancing mass inside, and this could be, based on its location, either a fibroid or a thickened endometrium from a endometrial cancer. There are other smaller calcified fibroids at the periphery, and so the next step in their management should be an MRI to further evaluate this mass, which may be a fibroid or an endometrial cancer. These are the images from their MRI. On the top, we have small field of view, T2 weighted images. This is the mass, a little bit heterogeneous, but mainly T2 hypointense. And we see this on the axial, coronal, and sagittal images. That's the rest of their uterus. The endometrium is not very clearly visualized in the region of the mass. The mass does not show restricted diffusion, but it does show variable enhancement. So whenever there is a focal lesion in the myometrium that is T2 hypointense, it has to be a fibroid. It could be a subserosal fibroid, it could be intramyometrial fibroid, or it could be a subendometrial fibroid or a polypoid fibroid going into the endometrial cavity or into the cervix. Sometimes they come down to the level of the vagina. They generally do not show restricted diffusion, but they show variable enhancement. In postmenopausal women, they become smaller in size and may atrophy and become calcified. Here's our next patient. Very interesting finding. They presented with abdominal pain, and a CT of the abdomen and pelvis was performed with IV contrast. And here we see that they have this very large abdominal wall hernia, and the hernia contains large bowel loops, it contains small bowel loops, and the interesting finding is right here. It contains an inflamed appendix, which is also seen here, a tubular structure with thick wall, enhancement, and distension. So very interesting case of acute appendicitis happening inside the hernia. They underwent surgery. This is our next patient. They were suspected of having a urothelial malignancy. These tumors are common in older men with history of smoking, and a CT urogram was performed. And what we know about these tumors is that they can arise anywhere from the tract extending from the kidneys through the ureters into the urinary bladder, and so the entire tract needs to be opacified so that if there are any tumors usually seen as filling defects can be identified. And so here in the renal collecting system there is a filling defect. Also in the proximal ureter there is a filling defect, and so this finding is consistent with the multifocal transitional cell carcinoma. This is our next patient. A CT of the abdomen and pelvis was performed without contrast, and they have a transplanted kidney in the left hemipelvis, and adjacent to the kidney there is a simple fluid collection which is having a mass effect on the urinary bladder, also seen right here. That's the fluid collection. No complexity there, no definite wall or any other findings associated with it, and here's their urinary bladder. So a collection like this is most likely to be a lymphocele which develops chronically in some of these patients after a renal transplant. You can do a MRI to further evaluate it. It will be simple cystic with T2 hyperintensity, no enhancement, low T1 signal, and no restricted diffusion. And you can do an FNA also to make a more definitive diagnosis. This is our next patient. They presented with jaundice, and we find that on their MRI images, this is the coronal T2 weighted image. The CBD is dilated, and there is a suspected mass at the ampulla. It shows low T2 signal. It's also seen right here. It shows restricted diffusion, high signal on DWI, low signal on ADC, and on the contrast enhanced images there is some enhancement. So this turned out to be a ampullary cancer. Here's our next patient. They were evaluated for a prostate cancer. We performed an MRI of the prostate, and the images on the top are small field of view T2 weighted images in all planes, the axial, the coronal, and the sagittal. We find that this low T2 signal focus in the right peripheral zone is the primary prostate cancer. On another view, we find that there is involvement of the seminal vesicle on this right side, and this is its appearance on the sagittal image. At different levels, we see contrast enhancement peripherally in the tumor and also involving the seminal vesicle. These are T1 weighted images, post contrast, fat saturated, and then the tumor itself shows restricted diffusion with high signal on DWI and low signal on ADC. And so MRI is essential for local staging, to give the tumor a Leyrat's category, to measure the tumor, to evaluate the different properties, its appearance on T2 weighted images, post-contrast images, if there is restricted diffusion, if there is capsular extension, if there is involvement of seminal vesicles, if there are any regional lymph nodes, and also if there are any bone mets in the bones that are included in the field of view. This is our next patient. They were suspected of having multiple tumors, enhancing foci on their CT of the abdomen and pelvis. But also it was reported that the spleen is absent and they may be splenoles. And so in this situation, you want to do a nuclear medicine sulfur colloid liver and spleen scan to make a diagnosis or rule out a diagnosis of splenosis. So we injected patient with sulfur colloid, and on this spot view of the abdomen, we find that there is physiologic uptake in the liver, and all of these enhancing foci that were seen in the CT of the abdomen and pelvis take up technetium-99m sulfur colloid, suggesting that they are splenoles and not tumors. This is our next patient, another MRI of the prostate for prostate cancer. The T2 weighted images in all three planes are on the top. That's our tumor in the left peripheral zone. Here is its appearance on the coronal image and the sagittal image. The tumor shows contrast enhancement. It shows restricted diffusion, high signal on DWI, low signal on ADC. And look at this focus right here. In the right ilium, there is a focus of enhancement, peripheral enhancement seen in the bones, and this is a bone metastasis. So remember to look at the bones when you're reading the MRI of the pelvis to evaluate a patient with prostate cancer. You may be able to pick up some bone mets that can show enhancement, as well as other things like restricted diffusion. This is our next patient. We performed an MRI of the abdomen without contrast. We can see that they are pregnant. This is their gravid uterus, also seen right here. Here is the placenta. And so abdominal pain, especially on the right side, is very common in pregnant patients. It could be because of appendicitis, hydronephrosis, or from cholecystitis. And so a MRI is performed to further evaluate these patients. We can see that the gallbladder here is normal, and the appendix is seen right here. It is enlarged and there is some surrounding fat stranding. All of these white linear foci that are seen around the distended appendix, that's fat stranding or signs of inflammation. And here is the ostium showing an appendicolith obstructing the ostium of the appendix, leading to acute appendicitis. And so that's how appendicitis would look like in a pregnant patient when they're complaining of abdominal pain and you want to rule out or evaluate them for acute appendicitis. Remember that these scans are performed without IV contrast. This is our next patient. We were evaluating an indeterminate liver lesion that appeared cystic on the CT scan. And so that's its appearance on T2 weighted image. It's T2 dark. Let's start by looking at the contrast enhanced images here on the top. So we are looking at T2 T1 weighted fat saturated post contrast images. This one is pre-contrast. This is arterial phase, portal venous delayed, and a further delayed phase. And so we notice right away that on the pre-contrast phase, this lesion is very T1 hyper intense, suggesting that there are blood products inside. There is no definite restricted diffusion in this lesion. And so putting all of these findings together, this is probably a hemorrhagic cyst in the kidney. This is our next patient, and they presented after prostatectomy for evaluation of rising PSA and a suspicion of recurrent prostate cancer. The finding is subtle. There is a nodular focus of enhancement at the site of anastomosis of the urinary bladder and the urethra, also seen right here. And so the next step here would be, or should be, an MRI. You can also do a PSMA PET-CT now. The MRI showed an abnormal finding, a nodular focus that was suggestive of recurrence of prostate cancer at the site of vesicourethral anastomosis. And this patient underwent a fluciclovine PET-CT. The rotating image, or the MIP image, shows an abnormal focus that localizes to that nodular density that was seen. And this is the PET-only image showing a good correlation between them, and a diagnosis of a small focus of recurrence at the site of vesicourethral anastomosis. And the rest of the scan shows no evidence of metastatic disease. Thank you for watching.